Hi, good evening. Welcome to February's Aging Well, and happy Valentine's Day to everybody. You know, we think of love in February, and especially on Valentine's Day. And I just always want to give a shout out to the Aging Well team, whom I love so much. There is no way we could do any of this without them. So a shout out always to Tom Roth with our CTSI, Courtney Hayes with Wake Forest School of Medicine, and Audrey Belfaro with our Alzheimer's Disease Research Center. There is no way we could do this without this team. And especially thank you to you for being here with us, for spending some of your Valentine's Day just with us, learning how to age well. You know, we were talking earlier about, I'm wondering if y'all even know the type of reach that Aging Well has developed. We now have 579 people who follow us on Aging Well. And we have folks, because I get reports after each one of these, we have folks who have joined us from England, Ireland, and Germany. So I'm excited that the message of, yes, we can age well is spreading not just throughout North Carolina, not just throughout the country, but, you know, over the pond. So anyway, thank you. Thank you so much for being here. We have an amazing program tonight, and we're going to get started with our food segment because we all love to eat. And we are going back to the Prescott restaurant. Owner and executive chef Trey Prescott is going to be showing how to make a very special grouper with a little surprise in the batter. So enjoy, and I promise you it's delish.
Thanks, Deb. Hi, Aging Well. Welcome to the Prescott. I've got some wonderful things to prepare for you today. Why don't you come on in and we'll try them out. All right, now we're in the kitchen. Let's get started. It is our tempura grouper with sauteed local kale over pecan cheddar grits. The first thing we're going to start out with is the grits that takes the longest to cook. What we've done here today is just softened up some stone ground grits in polenta with a little hot water and let it sit. And we're going to add cream, some nice local cream from Homeland Creamery, and some pecans, about 1/4 cup. To that, we're going to add about another cup of hot water. We'll get that all stirred around and soft. Put that on the heat. Nice low heat for 35 minutes, and your pecans will be done. Constantly stir them to make sure that the pecans get chopped up. And then once they're done, at the end, about 30-35 minutes, we're going to add some nice sharp white cheddar and some really good whole butter at the end. Also with this dish is the local kale. We like to use a lot of local ingredients here at the Prescott. Five Wood Farms is a farm that's located not even 2 miles away from us that provides us with several wonderful leafy vegetations. We got our microgreens, our salad greens, and these wonderful baby Russian kale from them. It's just one of the wonderful ingredients, just like this honey that we celebrate here at the Prescott. So next I'll be doing the sauteed kale. All right. Nice cast iron pan that we're going to get nice and hot. We're going to put in just a little bit of good whole butter. About a tablespoon of garlic. 4 cups of our washed and chopped local kale. Try to toss that around in there so the garlic doesn't get burned real quick, but the moisture in the kale should wilt out quickly, and it should give you enough temperature change in your pan that your garlic won't burn. Constantly keep it moving. And that cast iron is going to deliver a lot of very good flavor to the kale, and as well as retain the heat, so it's going to give it a nice crust when the moisture comes out. At this point, I'm going to season it with about a tablespoon of sugar. and just a pinch of salt. It has a nice sizzle to it. And just to add an extra layer of flavor, we're going to deglaze with just some nice cream sherry. And we're going to finish off with a nice couple of good tablespoons of butter. Right at the end, so it doesn't melt, and it's nice and soft butter, so it'll incorporate real well into the kale, like a sauce. We'll go ahead and cut our heat off at that point, and just let the residual heat from the kale melt the butter. And the sherry, the alcohol's cooked off, and now it's nice and soft. And we'll just let that finish in there. As you can see, there's a nice pan sauce made from the butter and the sherry, and just a little bit of moisture that comes out of the kale. We'll let that stay there while we drop in our tempura grouper. All right, now the main part of the dish is the tempura battered grouper. We like to do our tempura batter with a little bit of luxury here at the Prescott, by adding just a little bit of champagne at the end. And what we have here is a traditional tempura batter, which is a Japanese style batter made of egg yolks, flour, cornstarch, and cold ice water. It's important to keep it really cold. And then here at the Prescott, right at the end, we like to add a little champagne, just to add a little extra bubble and flavor to it. And we have our nice piece of grouper here, preferably off the North Carolina coast or South Carolina, but we have gotten this one from Florida. All we do for this to keep a nice light batter is we didn't do any pre-breading, so we just went right from the fish right into the batter, and we're going to season it with salt when it comes out, so we don't have to worry about the salt falling off. I'm using a glove in this case, but we're just going to dredge it nice in the champagne batter, and then we'll drop it into the hot oil over there. All right, we've got our oil at a nice 375 degrees. A candy thermometer on the side we just removed. It'll tell the temperature of it for you perfectly. And all you're going to do is, like I said, with a glove on, it's the safest. Make sure it's got a nice batter, let it drip off. And then the chef's secret is run it along the edge to get any excess batter off. And then you're going to slowly drop it into the oil. Not all at one time, just letting it kind of gently fry a little bit. And then we drop the whole thing. And it's a wonderful little protector, as usually your hands are covered in batter, as it won't get burned right there by the hot oil. Once you got it in there, 5 to 7 minutes, should be nice and golden brown. We'll take it out, generously hit it with salt, kosher salt, on the outside of it, because the oils that are still residual on the outside will help it stick to it. If you remember what we were doing with the kale earlier, we had mentioned deglazing. And deglazing is just what chefs call removing the fond, or the foundation, the little bits that have stuck to the bottom of the pan. And when we add a liquor or any kind of liquid, it helps remove those bits and helps become part of the sauce. And that's just one of the little chef tips that we have here at the restaurant. All right, now it's time to put it all together. We're going to start with the base of the plate is our grits. And it's just, just a reminder of our secret, putting pecans in the grits and letting them cook low and slow, constantly stirring them, breaking up the pecans little bit by little bit, adds such a nice nuttiness. And it's quite an accident that we stumbled upon it, but we absolutely love it here. And the aged white cheddar that we add at the end adds to the nuttiness and adds a wonderful bite with it. We're going to put the grits on first. And we finished them off with some more whole butter. Just lop those in there. And with cooking that long, the pecans have gotten soft and the grits have gotten all nice together. And these are stone ground grits that we got from the old mill, Guilford Mill. Next, we're going to add our wonderful kale, as you can see, sitting in our sauce. And we're just going to take all that beautiful sauce and all that kale, just lay that right on there. Wonderful smell to it. And then our wonderful champagne piece of grouper, tempura grouper. We're just going to drain that on a paper towel or a kitchen towel that we have. And like I said, nice sprinkling of salt right on the top. Make sure you get all the pieces of grouper. And we'll just layer that on top. And we're just going to finish off our wonderful tempura grouper with a nice lemon caper tartar sauce that we make here at the restaurant. But it's just a simple mayonnaise, chopped capers, lemon juice, red onion, and a little dill pepper relish. And to finish off our dish, we're going to use some of our wonderful locally grown edible flowers here that we get from Durbar Greens. We have some nasturtium that adds just a wonderful bite and lots of different arrays of flavor as you bite into it, and they just make the dish pop. And even though you might not have edible flowers at your house, it's still a very easy dish to execute in your home. Or you could come enjoy it here at the Prescott. We're located in downtown Kernersville at 126 South Main Street. We hope you enjoy it. Come to enjoy it.
You know, I will tell you that is one of my favorite dishes at the Prescott restaurant. So sometimes I use a little, I don't know, request if some of the chefs will make some of my favorite dishes. So I can attest that this one is fabulous. So anyway, moving on, you know, we talk about Winston-Salem being the town of arts and innovation. And this month we are just doing nothing but focusing on art, and specifically the art of weaving. There is an amazing place on Trade Street in downtown Winston-Salem called the Fiber Company. And in there is this phenomenal group of women who are weavers. And so Tommy Melson is one of the wonderful weavers there, and she is going to take us on a tour of the shop, but mostly how they do their weaving and the amazing garments and decorative accessories that you can make just from a loom. And I will tell you this, if there's interest of this group of the AgingWell folks, we're going to try to put together a class over at Sawtooth. So as you're watching this video, think about if this might be something you would enjoy doing. So without further ado, Tommy, take it away.
Hi, Deb. Thanks for coming into Fiber Company to do this segment for Aging Well. I'm real tickled to be involved in this wonderful project that you're doing. So my name is Tommy Melson. I live in Winston-Salem, North Carolina, and I'm 74 years old. So I'm trying to age well. I'm retired, but my vocation off and on over a very long career, and my avocation is that I'm a hand weaver. Weavers make cloth. We make cloth. And next to hunting, we are actually the world's oldest profession. So weaving's been around for thousands of years. Looms have been around for thousands of years, and basic looms haven't changed. Think about when you read Ulysses and Odysseus's wife Penelope was sitting there trying not to be forced into marriage, so she would weave and unweave, trying to keep the suitors at bay. So it's old, it's an old profession. It's a fabulous thing to do. It's quite physical, but not too much. You exercise your arms, your legs, your shoulders. It can be very simple or it can be very complex. And you will find looms similar to mine in every culture around the planet. Think of paintings of the Renaissance and amazing, gorgeous clothing, hand woven. And that was recent, that was the 1400s. At any rate, so this is our little shop. At our core, we are weavers, although we represent a lot of other folks in our shop. Almost everything in here is handmade, but let's just look at some cloth and some weaving, and then we'll go to the loom and talk about the process itself. That work for you? So when I said weaving was the oldest profession, if you will, probably the very first things that were woven would have been shelter, a roof over your head of palm leaves, a hat. But of course, that quickly led into garments. And of the 5 weavers in this shop, most of us still make garments. This coat, for example, isn't this gorgeous? It's hand-woven cottons by Jane Dabb, who's one of our partners. And in a minute, see how beautiful it is, all the wonderful texture, all the different sections in it. We'll take a look at the loom and see how the cloth starts pretty but plain. And then this is what it's going to turn into. And part of what's fun about these coats is they're based on a Tibetan pattern. The coat pattern is from Tibet. So, weaving all around the world. Let's walk back and look at a loom. So we just looked at that beautiful Tibetan coat hand woven by Jane Dabb. This is one of her looms, and right now Deb's showing us just the fabric. It's what is called a plain weave fabric. It's a lovely array of color, but the weaving itself isn't particularly fancy. But it's on what's called a standard 4-harness loom. Deb, can you pull back and show us this loom? Okay, so a real simple contraption. This is not my loom. I'm not going to mess with Jane's fabric, but I want to show you basically how it works. So these are the harnesses, and through these little heddles on the harness is 1 thread per heddle, and they're attached to foot pedals. So when I push the foot pedal, it lifts these harnesses and it makes a space. It makes a space to throw the yarn through. Then you beat the beater. Then you push a different foot pedal and a different arrangement of threads come up. You make a space, you throw the yarn through. Since it's not my loom, I'm not going to throw any yarn through. But that, in essence, is how weaving works. The very earliest looms were just a frame, and you'd line up the threads on the frame, called the warp. This is the warp. And then just with your fingers, you would pick up threads to go over and under, over and under, over and under. The great Persian carpets are woven on frame looms, literally reaching in and picking up this thread, this thread, this thread, and taking the yarn through. Beautiful Navajo rugs, same thing, simple frame, picking up the threads you want. So sometime, I don't know, the 1400s, no, much earlier, a 4-harness loom was developed where you could foot power it and raise the threads that way. So that's why when you think back to those Medici paintings and these incredibly complex cloth, by then foot power looms were highly advanced. And this is a highly advanced loom. At some point, if we have chance, I'll just show you a picture in a book of some of the super complex stuff you can weave on just a 4-harness loom like this. But this really pretty, rather plain cloth is going to become a coat like the one we looked at. So here I am sitting at one of my looms. And I mentioned when we first started talking that weaving is physical. It can be a lot, it can be really physical if you're in a big giant loom or you're weaving a rug where you're really beating, or it can be lightly physical. It's something that any person can adapt to their own strength and physicality, and it'll build strength as well. So at my foot-powered loom, I'm just going to do some plain weaving, but I'm using my legs. I'm having to push down, Get this little thigh muscle going in order to lift up the harness. Then I'm going to reach out, stretching sideways, throw my shuttle, use this part of my arm, change feet, push up the other one. Now I'm going to beat my thread forward. Then using this arm, I'm reaching out, I'm stretching here, I'm using this hand, I'm flexing it, I'm throwing that shuttle. I'm letting my harness down, I'm beating it, then I'm changing again. So when you're really speed weaving, and I am not a speed weaver, you're really building a nice little rhythm. It may not be the cardio of running a 20K, but it gets you moving. And it's hands, arms, legs coordinating together. So that's the physicality of it. But you can also slow down. If I were weaving a Navajo rug or tapestry, I'd be going a lot slower because I'd be making constant decisions about what color to use, how far to weave with it. But it's a nice round physical movement. And if I had you in a loom, I could teach you the basics of weaving, the basics, and get you underway in probably 5 classes, and then give you a vision of possibilities. So that's the basic weaving part. Legs lifting, pushing, if you will, arms stretching, throwing, beating. So you're stretching this way, you're stretching this way. The feet and the legs are working. So that's the basic physicality of a floor loom. So come weave with me. So we were just sitting at the loom and I was showing the basics of how it worked and what was going on physically. And knowing Deb was going to come to the fiber company today, I got to a point in my weaving where I could just do the plain weaving and you could see the moving. But in my youth, I wove garments. Now I'm 74 and kind of lazy. So mainly I weave pillows. So what you saw was a plain weave. Here's a pillow I've woven. Here's just the back of the pillow, the plain weave. But I'm mainly a wool and mohair weaver. I'm very interested in texture. When I talked about doing the slower parts, what you didn't see on my loom because it had rolled around the beam, what's going to be the front of the pillow, the high texture pillow. And in just a 4-harness loom set up for plain weaving, you get more than just the plain part. You can make twills. See, can you see the little twills in there, the little diamonds going on? So your blue jeans, anyone with any sense that's retired is wearing blue jeans part of the time, that's a twill. So with those 4 harnesses, I could just pick up every 4th thread and make this big lumpy stuff. I started weaving in the 60s, back in the days of big lumpy, kind of hippy-dippy stuff. So at any rate, there's a tremendous amount of choices when you're a weaver. And they're not all made at the loom. They start with, what am I going to make? What kind of yarn do I want to use? What colors do I want? What's the finished product going to be? How am I going to thread the loom? So besides the physicality, everything we do, of course, is mind, body, brain coordination. But the options and the choices are constant. So starting from the very beginning, you're making constant choices, constant choices. So this one is off the same red warp as this pillow. Same warp on the loom. But I wanted some purple. So instead of picking red yarns, I was picking purple yarns. So that's just a little bit about what I'm doing right now. But on that plain weave, I'm just going to get out of frame here and show you. Here's a sample of rugs. And this little pattern, so this is made on just a plain weave. The warp is spread out more so that the weft, the part I'm throwing across, is totally covering the warp to make a thick, crunchy rug. And this pattern right here, I just love that, is based on a Navajo saddle blanket. This is a pattern that Navajo weavers would weave to make big, thick saddle blankets for their horses. So just an aside, done on just a plain 4-harness loom. And one of the traditions in North Carolina, in the Appalachians, of course, is rag rugs. And people still weave them, we still use them. So here's just another little sample of rag rugs. And I wove this sample probably 25 years or so ago. And it's still my bath, the actual rug I wove from, it's still my bath mat. So rags, but they wear forever. Anyway, just a little vision of possibilities. Let me show you one more thing, and it's a picture in a book. But to give you a vision of possibilities from plain weaving. So we were talking a little bit about the kind of the brain-body connection and the scope of possibilities that you have in weaving, particularly if you've got a nice 4-harness loom. So the plain weave we looked at, that pretty purple cloth we first looked at that I said was going to become like that beautiful red coat. Plain weave, here it is, plain weave. But on a simple 4-harness loom, you could do this. Very complex, but just on a 4-harness loom. It's called an overshot pattern, and here in North Carolina, Tennessee, West Virginia is a whole tradition of coverlets, overshot coverlets. This one, the threading across the loom, across the beam here, one whole threading, makes this quilt, or this bed cover. This would be a double-sized bed cover if you wove it as written. So just on a 4-harness loom, you could do something what appears to be super complex. This again is part of what would become traditionally an Appalachian coverlet. So the scope of possibilities with weaving, and I would say really with any craft, whether it's potting, metalworking, they're all physical, but the scope of possibilities, I think about weaving like I think about the piano. I'm not a musician, but I'm married to one, but I could teach you how to play Twinkle, Twinkle, Little Star in just a couple hours. But you could start with that and play piano all your life and never, ever run out of options, opportunities, inspiration. And weaving's just the same way. So I learned to weave at the Sawtooth School for Visual Art, as did my partners here, actually, all 4 of us, many years ago. And so frequently people come into the fiber company and say, well, can you teach us how to weave? And we're like, no, we have this great art school here. But if any of you want to weave, learn how to weave, get in touch with Deb, because I think the Sawtooth would be pretty excited maybe to set up a class for we seniors who want to stay vital, interested, hopefully smart. So at any rate, hopefully you've gotten a little bit of idea about weaving and it interests you, and if so, give Deb a call. And thanks for coming to visit us. Thanks for this opportunity.
This was such a fun time. And Tommy is, again, as you can tell, she's amazing. But if anyone really wants to join me, because I told her, I said, I would love to do this, email me or call me. Y'all always have my information from my emails. Let me know the interest and I'll sure follow up and see if Sawtooth can put together a class for us. Because I think in addition to making something beautiful, I think we'd have a lot of fun. Anyway. And now to get on to the education component of tonight's Aging Well, Dr. Molly Hartzler is an assistant professor in orthopedic surgery at Atrium Health Wake Forest Baptist at Davie Medical Center. And she is going to share with us how we can love our joints. You see how we tied it back into Valentine's, don't you? So Dr. Hartzler, I'll turn it over to you and can't wait to hear what you have to share.
All right, great. Thank you. Let me share my screen here. And we'll get going. All right. Does that look okay, Deb?
Yeah, looks great.
Okay, perfect. So thank you so much for inviting me to be here tonight, and thanks for all the participants. As Deb said, I'm an orthopedic surgeon and I specialize in hip and knee reconstructive surgery. And so hip and knee arthritis is my focus. A lot of the principles that I'll talk about for preserving your joints are true of other other joints, because you can have arthritis obviously in any joint in your body. The hips and knees are just a little bit different because there are weight-bearing joints. So we really put them through a lot. And when they start to get painful, it can really impact our lives because walking is so important. So with that, let's just talk a little bit about what arthritis is. So a lot of the patients who come in to see me, they don't really understand this term. And arthritis is just a generic term. It means that you have pain in your joint. So when I'm seeing patients, they can have pain in their joint and joint destruction from a lot of different things. The most common thing I see is this osteoarthritis, which is just kind of wear and tear type arthritis. People can also have arthritis caused by previous injuries. We call that post-traumatic arthritis. People who have inflammatory or autoimmune conditions can often have arthritis that's associated with it and can cause pain, but also damage to their joints. And then there's a variety of other types of conditions, such as congenital deformities, sickle cell anemia, avascular necrosis, and the list really kind of goes on for other things that can cause arthritis as sort of a side effect of a condition. So osteoarthritis is really the most common thing. That's sort of your wear and tear. You know, people who have really physical jobs for their entire lives tend to have this. There's some predisposing factors. Sometimes I'll have patients come in and tell me, well, my mom had both her hips replaced and my grandma had both her hips replaced and all of my brothers and sisters have all their hips replaced. And so, you know, there's something going on in their family that's predisposing them to this condition. And these are just some schematics showing sort of what's going on inside the hip and the knee. So on the left side of the screen, we have a representation of a healthy joint. On that side, that kind of blush color is the cartilage surface. Cartilage is the tissue type that we want to be nice and healthy and thick in our knee joint. That's the right and our hip joint, all of our joints really. It's the right surface to walk on because it doesn't have a lot of nerve endings and it's nice and cushiony. And then the picture next to that, the one in the middle, shows exposed bone. When the cartilage starts to wear away and the bones start to rub together, it's quite painful. And that's where we get that term bone-on-bone arthritis, if you've ever heard that. And then on the hip side, it's a little harder to appreciate the cartilage wear. What we can see on that picture is sort of the bony outgrowth or the bone spurs that you can see from someone's arthritic hip joint. Post-traumatic arthritis is a big cause of arthritis. So people can have a variety of types of injuries, and anything that damages the cartilage has the chance to lead you down the path to have arthritis. So, you know, there's this sort of classification system showing a knee, a distal femur, and the different types of fractures that can happen. And a lot of those go through the cartilage surface. Unfortunately, cartilage is a very fragile tissue. It doesn't have a blood supply. It actually gets its nourishment from the joint fluid that the lining of the joint is producing. And so if it gets damaged, it really does not have a great capacity to heal. And then likewise, you know, a hip dislocation typically causes a good amount of cartilage damage and breaks around the hip and pelvis as well. And then there's these inflammatory autoimmune conditions. I have a lot of patients who've had lifelong rheumatoid arthritis or lupus. The middle picture is psoriasis, so psoriatic arthritis is something that can happen. And then for those of you who might have heard of AVN or avascular necrosis bone, the hip x-ray on the right shows a healthy hip, and then one where the blood supply to the femoral head or the top part of that femur bone has been disrupted, and the integrity of the bone is disrupted as well. It can't remodel the same way that it normally would according to body stress. And so it starts to collapse down. And these folks typically have a shortened limb, and it can be very painful prior to their hip replacement. So whatever the cause of the arthritis is, it sort of leads down this final common pathway, which is loss of cartilage in the joint, and then inflammation of the joint lining. That's the lining that produces the fluid. And so as it becomes more inflamed, the fluid can build up. In the knee, people tend to notice the swelling a lot more than in their hip joint. And the increased fluid can actually be pushed out the back of the capsule and cause what's called a Baker's cyst. The Baker's cyst can be drained, but the real treatment for a Baker's cyst is actually just treating the arthritis. And then formation of bone spurs, which are those little bony outgrowths. We call those osteophytes, and then formation of cysts in the bone. So preventing arthritis. So One of the biggest things that patients can do to prevent their chances of becoming arthritic down the line is weight management. And it's a difficult discussion to have with people. People understandably are, weight is a very personal thing. And so when talking to patients, I always try to tell them that their weight is not a big deal to me, with the exception that it does predispose them to arthritis, and it does cause more pain around the joint. And any discussion that I try to have with patients regarding weight loss, I try to frame it in a very loving way, that I'm trying to help them and not trying to make them feel bad or deny them care. But we do have studies showing that obesity increases the risk of osteoarthritis by 4 to 5 times. And fatty tissue or adipose tissue is actually an inflammatory tissue all by itself. It produces molecules called cytokines, which cause inflammation and pain and can contribute to pain in people's joints. And then the other thing is that hips and knees feel about 3 to 6 times the force for every additional pound that someone's carrying around. So even 10 extra pounds can be a lot of force across your hips and your knees because they're carrying your entire body's weight. And as we take each step, the muscles around our joints are contracting. So it's not just the weight that's on top of the joint, it's also the contraction of the muscles around it, adding that weight and causing extra pain. So preventing arthritis, avoiding injury, it's, sounds like, oh, well, who would want to get injured on purpose? But there are people who have some high risk hobbies, like motocross comes to mind. In my residency, we'd always have a really exciting time when the motocross competitions were around. And so there are certain hobbies and activities that can really predispose people to injury. So avoiding those types of things, in my opinion, is a good idea. Managing autoimmune diseases. I've had some patients that are really reticent to start disease modifying drugs, but they've made a huge difference in the amount of inflammatory arthritis that orthopedic surgeons see in their office. So if you have an inflammatory condition or an autoimmune condition, talking to your rheumatologist about what's available and the risks and benefits is really important. And then, of course, minimizing or eliminating bad habits. And, this is about aging well and living well. And so, we know that minimizing bad habits is a good idea anyway, but these are things that really can lead to worse pain or worsening joint disease. So heavy alcohol use is the #1 risk factor for AVN of bone. And smoking has been linked to worse disease states in osteoarthritis and rheumatoid arthritis. And if you end up needing a surgery, we always ask our patients to quit so that they have a less chance of complications around the time of surgery. So this is one that I love talking to patients about, although it's kind of a hard topic because every single person who comes into my office has joint pain. And so telling them to go out and exercise, they look at me like, are you crazy? I can't exercise. That's why I'm here. So if you are not somebody who has arthritis, exercising is a great way to prevent it. Even running, a lot of people think that running is going to cause people to have hip or knee arthritis, and it hasn't been shown to be true. I think probably some of it is that people who are runners have an easier time kind of managing their weight. But sort of that moderate impact exercise, especially in shorter distances like 1 to 3 miles, really hasn't been proven to cause arthritis. People who already have arthritis, they have improvements in pain if they stay active. So when people start to have joint pains, they tend to become more sedentary, and then they become more weak, and they have less dynamic support around their joints because the muscles and ligaments and tendons and everything that cross the joint are really important for the stability. So it's sort of this, vicious cycle of it hurts, so I stopped exercising, so it hurts worse, and I really can't get moving again. And then the biggest conversation that I have with people who come into my office is, what kind of things can I do if I have joint pain? 100% of the time, I recommend getting in the pool in some capacity if you can, and you don't hate it. And you don't have to be Michael Phelps, lap swimming is great, but if you don't know how to do those things or you can't, just walking back and forth in the pool can be wonderful. You have resistance from the water, but the water also takes the weight off of your joints. So you can really get kind of a good exercise and do some strengthening. And then water aerobics classes are also wonderful. I like to recommend cycling, especially recumbent bikes. They tend to be more comfortable, and you can adjust the seat forward and back. So if it hurts your hip or knee to deeply bend it, you can move your seat back further away so that your revolutions are kind of smaller and your hip and knee aren't moving quite as much. And then yoga and Pilates are wonderful. They're great weight bearing exercises. They're good for people with osteoporosis. They help you maintain flexibility, and they really focus a lot on core strength, which is really important in my patients who have hip pain. It's really important in everybody, but especially for people with hip pain and back pain, these are wonderful exercises. With that being said, for most people, if they can tolerate the exercise and they enjoy doing it, I encourage them to continue. So what do you do if you have hip or knee pain? This is the question that comes up very often. And you don't actually have to go to the doctor right away if you start to notice that you're having some soreness in a hip or knee. You can self-treat to a certain extent. So over-the-counter medications, as long as you don't have health conditions that prevent you from taking Advil or Tylenol, and you're following the instructions on the bottle, they can be extremely effective on an as-needed basis for these little aches and pains. Ice, heat, and topicals can also be really helpful. And then there are a variety of over-the-counter sleeves and braces that can help to stabilize joints. And the last one, anti-inflammatory diet. I was at our big hip and knee conference a few years ago, and there was an anesthesiologist presenting from Vanderbilt University, and she was part of their pain group. And she had some really interesting data on anti-inflammatory diets showing that they were super effective for patients with chronic pain, and people who followed an anti-inflammatory diet had an easier time getting off chronic narcotics. And I thought that that was really powerful. So it just kind of goes back to this idea of, taking really good care of your body kind of in a holistic manner. If you do reading on anti-inflammatory diets, there's sort of a variety of recommendations about which things you should and shouldn't eat. But sort of the bottom line is if you're sticking to kind of whole foods and eating a lot of fruits and vegetables, those are anti-inflammatory foods. So if you're trying to self-treat and you're still having problems and it's starting to get in the way of your life, talk to your primary care physician. They really can do a whole lot in terms of treating you for musculoskeletal pain. There are a few anti-inflammatories that are prescription strength that you can try, and they may prescribe you physical therapy, which as you can tell, I'm a big proponent of staying active and doing physical therapy. So if they recommend it, I recommend that you go ahead and do it and give it a really good try before giving up on it. Some primary care physicians are comfortable offering injections. So steroids can be an option, or what's called viscosupplementation. It's a hyaluronic acid and it's supposed to cushion the joint. And then most of them will order some type of imaging to confirm that you do have arthritic change in your joint. So if you are failing treatment with your primary care physician, or they look at your x-ray and they're like, oh my gosh, this person needs to see a surgeon, then they'll probably refer you to somebody like me. And just because you come into my office does not mean that I'm going to recommend a surgery. I always try to treat patients with non-operative treatments for as long as we can, keeping them comfortable and active prior to moving ahead with surgical intervention. For some patients, I will order an MRI or a CT scan, which is advanced imaging, but the majority of my patients that come in, I can get everything that I need from just a plain x-ray like the one that you see there. Sometimes I refer my patients to spine doctors. The hip and the back are very close neighbors to each other, and so it can be confusing sometimes to know if the hip is causing a problem, if the back is causing a problem. So it can be helpful to get another opinion. And then depending on the patient's history, physical exam and x-rays, I may suggest that we go ahead with joint replacement. Like what you see there, that's an x-ray of a hip replacement that I did for a lady. So a couple of good things to know, not all hip and knee pain is arthritis. So there are soft tissues all around our hips and our knees and all of our other joints. And those are things that can cause you pain. So bursitis is very common, especially as we age, and they can manifest as hip pain. it's kind of interesting. A lot of patients, when I ask them where their pain is, they'll say the hip and then point to the outside. As you can see there on the left, true hip pain is pointing at the groin. So I have some patients sometimes who are frustrated because they've been worked up for other things, like for instance, an inguinal hernia for a long time before somebody finally realized that it was their hip. But hip pain typically manifests as groin pain, and pain that is lateral is typically soft tissue pain. And then around the knee, there's a bunch of bursa. The knee is incredibly complex. There are lots of ligaments and tendons that cross the knee, and a variety of things that can cause pain other than the bones themselves. And then this is something that I spend a lot of time with patients on as well. So these schematics are trying to communicate that pain can be referred. So the example that I use is when somebody's having a heart attack, sometimes their chest doesn't hurt, but their arm does, because the way that our peripheral nerves come out of our spinal cord and travel around our body, anything that is sort of upstream can cause pain downstream. So I will sometimes have patients come in with hip pain and a perfectly normal hip x-ray, and it's actually their back that's the problem because the nerve is getting pinched when it's coming out of the spine. And I sometimes have patients come in with knee pain and a perfectly normal knee x-ray, but an arthritic hip, and their hip pain is radiating down their knee. So it's not always completely straightforward to figure out what's the source of this pain. And sometimes we will use a series of diagnostic injections, numbing things to find out if it helped with the pain. Sometimes patients are a little frustrated, like, why can't we just figure this out and do the right surgery? But of course, doing surgery is a big deal. And so I always try to make sure that I know exactly where each and every pain is coming from prior to suggesting that we do something invasive. So not all arthritis needs joint replacement. So the biggest reason, the only reason really to have a joint replacement surgery is that you have arthritis and you have pain, and that pain cannot be controlled any other way. So sometimes I'll have patients come in and they have severe arthritic change, but they tell me it doesn't really bother them that much. They take some Advil and they can kind of do their daily life, and they're really not interested in surgery. So that person, I tell them, great, nice to meet you. Call me if that changes. And then I'll have another set of patients where they come in, they have pain that's local to that joint, but I can't find a source of pain based on imaging and exam. So that person is also destined to failure if we were to do a joint replacement on them. So the arthritis with pain that cannot be relieved any other way, that's the indication to have a hip or a knee replacement. So just a little bit about hip replacement. So there's a variety of approaches that exist. Surgeons have done a good job marketing different approaches. And so we have patients who have done research and they've read that one way is better than the other way. And do you do this or do you do that? But physicians typically choose the approach as well as the implants that they're going to use based on the patient characteristics and their own comfort and experience with each system. Hip replacement is my favorite operation. It's considered one of the most successful operations in medicine because the risks are pretty low and the satisfaction is incredibly high. The vast majority of my patients who have hip replacement surgery have less pain when they wake up from their surgery than they did when they went to sleep. And if you think about, the fact that you have to cut somebody open to do a surgery and then they wake up feeling better, that's pretty amazing. People usually say they wish that they hadn't put it off. Of course, people have trepidation with undergoing elective surgery, so it's understandable, but patients tend to do really, really well. Knee replacement surgery is a little bit similar. There's one approach, one way to get into the knee, but then once you're inside, you can do a robotic versus a navigated versus manual techniques. There are a variety of implants, just like hip replacements, but my analogy for patients in my clinic is it's a little bit like a Honda versus a Toyota. They have some different specs, but the general idea is the same. And again, physicians will make the choices based on the patient characteristic and their own comfort levels. Knee replacement is a little bit more difficult for patients. The first couple of weeks after the knee replacement are really unpleasant, and there is a lot of rehab that goes into it. And then the last thing to know is that mechanical knees never totally feel normal. They click because they're made out of metal and plastic. And despite engineering best efforts, they don't completely move the same way as a native knee. But that being said, for patients who are having severe daily pain with arthritis and it's just ruining their lives, they do really, really well and typically end up getting back to everything that they want to do. So for people who have had their hip or knee replaced, you know, what do you do now? And I don't put activity restrictions on my patients. I want them to do their therapy, get strong, and when they feel ready, start to resume the activities that they were avoiding because of their pain. Surgeons will differ based on, based on their restrictions, but I think more and more joint replacement surgeons are moving towards not placing restrictions on patients. There was a study done a few years ago about whether or not patients adhered to the restrictions that their physicians gave them. And it turns out people kind of do whatever they want to anyway, as long as it doesn't hurt. So people based on that have decided to kind of loosen up because overall patients are still doing very well and their replacements are lasting a very long time despite doing the activities that they feel like. So this is one of the things that I tell my patients as we're going into the hip or knee replacement, because there's a number of reasons that hip or knee replacements can fail. And the biggest thing that patients can do to keep their hip or knee replacement healthy is just to take really great care of their body. The people that I see who are coming in 20 or 30 years later with failure, most often they've let themselves go. They haven't controlled their diabetes. They're not looking at their feet to see if they have sores. They're not they're not keeping their nutrition on point, things like that. So regular movement, good eating, good oral hygiene, and for people who have diabetes, just making sure you're doing as well as you can with your blood sugar and looking at your feet every single day if you can't feel them perfectly. So I just put a couple lists of, myths or things that people ask me frequently about arthritis or total joint arthroplasty. And I already touched on this one, but if I have arthritis, I need a joint replacement. And people who have arthritis, if they're tolerating their discomfort or if they don't have discomfort, they can just keep living their lives. Every once in a while, there are patients whose bone is collapsing, or there are other reasons that I might nudge them towards having surgery sooner than later. But in general, it's 100% symptom-based. The second one, getting my total joint will mean I will lose weight after surgery because I can exercise. This is one that we talk about a lot in the clinic because there is evidence from our body of literature showing that as people's BMI increases, their risk of complications increase. And so there more and more there are hospitals and systems that will not allow us to do surgery if patients are over a certain BMI, right or wrong. It's the thing that's going on right now. And a lot of patients will tell me, well, I can't exercise. So how am I supposed to lose weight? If you just do the replacement, then I'll get moving and everything will be great. And that may be true, but there have been no studies showing that patients who were unable to lose weight prior to surgery will lose it afterwards. So what we know about weight loss and BMI reduction is that sustainable dietary changes are really the only way to have effective weight loss. I can go run 5 miles on a treadmill and then sit down and eat that number of calories in 5 minutes. So it's going to be all about changing eating, moderating eating, and making sustainable changes. So the next one, after my total joint, my hip or knee will never hurt again. And if it does, there's definitely something wrong with my replacement. So the joint replacement will only take away pain that's happening from the bones rubbing together, that bone on bone arthritis. And so when I have patients that I replace their joint and then they go off and get active again, they sometimes have muscle pain or tendonitis or other problems. And often people come in a panic because this shouldn't be happening, this shouldn't be hurting. So just like starting any new exercise or any new activity, when you get going again after your joint replacement, or if you overdo it, you can and probably will have pain, inflammation, and swelling in the joint. It's always great to let your doctor know if you're having a problem, but they may find nothing wrong and ask you to just rest, maybe do some rehab, try some anti-inflammatories, things like that. There's a myth that people have to be at least a certain number of years old. 50 is a popular number that patients will tell me some other doctor told them. Or people will come in thinking, well, I'm 80 or I'm 85 or I'm whatever age, I'm too old to have this. And the truth is that if you have end-stage arthritis and you have pain that you can't control any other way, you are eligible to have a joint replacement. People can get avascular necrosis in their 20s and be hobbling around. I have had patients in their 90s who are perfectly healthy, much healthier than some of my younger patients, and will go ahead and do their joint replacement. So it's all about, surgeon comfort, but there's no hard and fast rules when it comes to those types of things. This is one I get a lot, actually. If I have arthritis, I should just go ahead and do the surgery before it's too late, even if it doesn't hurt that bad. And a lot of times this will come from somebody that they have had severe pain in one joint and milder pain in the other one, and we have done one of their replacements. And it's an individualized thing, but every surgery has risks. And so I always encourage my patients to wait until they are truly in enough pain to make those risks worthwhile. Even if everything went perfect on the first side, there's no guarantee that that's going to happen on the other side. And some of these, risks can be pretty life-changing. So it's all symptom driven. And as I told you before, there's really almost no such thing as too late. So, waiting until the time is right is always wise. And then the last two myths they kind of speak to those approaches and research that patients do and the advertisements that surgeons will do. So anterior approach, which I do, I love the anterior approach, but it's newer. And so some surgeons have advertised it as being better. And a lot of patients will come in and say, well, I only want this. And all approaches have risks and benefits. There are risks with the anterior, just like the posterior, and really the best outcome that you're going to get is from having the surgeon that you go to do what they do best. If you're really dedicated to having an anterior approach, you find an anterior approach surgeon who's an expert in high volume and has good outcomes, and you'll do great. But if you find yourself with a posterior approach surgeon, there is nothing wrong with it. Those patients do fantastic as well. And same thing for the robotic knee. So the robot is really attractive. It's like, oh, there's, this technology that's going to help me. But all of the studies that we've done show that, surgeons, like everybody else, are on a bell curve. And so, there are surgeons who are kind of outliers, like their patients don't do quite as well. And the robots tighten up that curve. They help surgeons who, maybe they haven't been having the best outcomes. That's not to say that surgeons who use the robot are not good, because I have fantastic surgeons that I know that typically use it for every case, and they have their own reasons for doing so. But what I'm trying to say is that if you find somebody that does not use a robot or a navigation system, that doesn't mean that they don't have good outcomes. It's one of those things that surgeons will use as an advertising tool, but may not actually make a difference in their outcomes. So that is my last slide. I have a question slide. So if anybody has questions that they would like to ask me, we have a couple of minutes.
Well, we already have one. And the question is, great presentation. I was wondering, does eating healthy and doing exercise reverse the osteoarthritis?
So it doesn't reverse the physical changes that have taken place. However, the eating healthy and the exercise can both reduce the amount of pain that you feel from the arthritis. So pain is really interesting, especially as a surgeon. I've gotten to appreciate more and more how interesting pain is, because you can have two people's x-rays with the exact same amount of arthritis, and one person is in a wheelchair and the other person has no problem at all. And likewise, you can have somebody whose x-ray changes very little and their pain really increases or really decreases. So we do have studies showing that anti-inflammatory diets or healthy eating makes you feel better overall, and that's true of your joints. And then we also have studies showing that patients who stay active, who stay strong, who do physical therapy, they have decreases in their pain over time.
We have another question. What about supplements, over-the-counter supplements, such as, I don't have any examples.
Yeah, so glucosamine and chondroitin are a couple of the supplements that often come up in my office. And again, I try to be a literature-based surgeon, and there are no, to my knowledge, there are no studies, so randomized blinded control trials showing that those things are helpful. However, I do have patient testimonials saying, when I stop taking my glucosamine and chondroitin, I start to have way worse pain. So if people ask me about it and they haven't tried it, what I tell them is if it's not financially prohibitive to try it, then there's probably no harm in it. There aren't a lot of side effects that I know of. But if it's something where you look at the price tag and you're like, oh, whoa, it's not like you're missing out on anything. So that's kind of how I fall down on that.
And I guess along that same line, what about stem cell injections?
Yeah, that's a good question. So stem cell or PRP, which is platelet-rich plasma, has a lot of attention. And I know that in like the shoulder literature, so like a non-weight bearing joint, we use our shoulders, but it's not carrying hundreds of pounds like our hips and knees are. People do get better with PRP, but in the hip and knee world, there has not been any study that shows that. And the reason that's important is because those procedures are not covered by insurance, and the out-of-pocket cost is typically in the thousands. And so I really hate it when I have patients who come in and they've had these and they tell me, we saved up for this and we spent all of this money. And I just wish that I would have talked to them first, because they're not better, and then they're out all of that money. So I recommend against, if money is no object to you and you want to try it, then that's one thing. But for most people, I don't recommend.
Okay. Well, Dr. Hartzler, thank you so much. I have certainly learned a lot, and I'm sure all of our attendees. Oh, here's some more questions.
Oh yeah, let's have them.
Well, so hang on just one second.
Okay.
If you have low bone density, are you a likely candidate for hip replacement?
Yeah. Yes. So I would say the vast majority of my female patients do have some sort of low bone density issue, osteopenia or osteoporosis. And that influences my choice of techniques and implants, but it does not preclude anyone from having a joint replacement.
Do we always need to listen to our body and exercise? If it hurts, don't push it further.
Yeah, so that's a great question. The answer is it depends. So if you are really worried about it, I would encourage you to go talk to your primary care physician, or if you have an orthopedic surgeon. And when I'm talking to a patient, I'm looking at their x-rays. That's when I say, you know what, if you enjoy going on long walks and it bothers you, push past it. If you feel like it, you're not going to cause any damage to yourself. Or if I'm looking at their x-ray, I might say, hey, I wouldn't push it too hard because you're losing your bone or other things like that are happening. So, especially in physical therapy tends to have some pain that goes with it. And I'm speaking from experience. So if your physical therapist is having you do exercises, you may need to push through some of that pain before you start to feel better, especially if you have tendonitis, tendinopathy, other things like that, soft tissue problems. That inflammation is going to be painful no matter what. And so while you're doing your physical therapy, you're going to have that pain. And then as you work through the problem, it's going to get better. But it's a hard question to answer sort of in general, because everybody's problems are so different and what they want to be doing is so different. So I hate to sound, like an infomercial or whatever, but you kind of need to talk to your doctor about it because everybody's different.
Okay. Well, I think you have answered our questions. I am so grateful for you presenting this information. I know, again, I've learned a lot, and I thank you. I thank all of you for joining us tonight, and please make a date to be here again on March 14th, and same channel, same time, and we will see you soon.